Ladies and gentlemen, I would like to introduce our next guest speaker, which is Ras. And Ras is a GP, trainer and mentor working at the Thukral practice in Sheffield. He's the education lead for the local primary care network. And he has interests in lifestyle medicine and in particular culinary medicine. And that's how Lindsay met Ras when he got in touch to do a recipe book. So over to you, Ras. Sandra, okay. Sandra as well. You can use the big
Thank you. Yeah, well, nice to meet everyone. We'll be able to get the slides up. Yeah, that's okay.
You can use the Elvis mic again.
Oh, okay. Busy mic. So I'm here today to talk about who in particular can help you from your GP surgery. The reason I want to talk about this is the who in a GP surgery now is very, very different to what people think or what people are used to. So you're probably historically used to either seeing your GP, your nurse, or a HCA in general practice, but that has really, really drastically changed over the past few years. And on the surface,
would you be okay to use the microphone? That one's
okay, yeah.
not actually connected. So.
Hello.
Thank you.
Perfect. Yeah. Cool. Thank you. So who works in a GP surgery is really quite different to what it used to. And there's a few other changes. If you go back sort of 10, 20 years, GP surgeries now are much, much larger organizations. And even though the GP practice on the surface might look very, very similar, in the background, a lot of practices have merged, getting larger patient numbers. And as a result, there's a lot of different types of people working in a surgery. The other thing that people might not be aware of is all surgeries belong to something called a PCN, which is a primary care network. And this is a group of local practices, usually between about sort of 4 to 8 practices that share some services between themselves. So, for example, a single practice might not want a dietitian for themselves, but between 4 or 5 practices, having a dietitian might be beneficial. So there's certain people that work in the PCN, and these people will be based in one of those surgeries. So this is what you might think of a GP surgery, but it probably looks a bit more like this. And there's lots and lots of different people working in there. So what I thought would be useful to do is really to go through some of these roles, okay? Technical difficulties.
I was just chatting to somebody online.
Okay.
So,
cool. To also make that very clear, so this is your GP surgery. So, and that sits within this thing called a PCN. So you get people working here, you get people working at this level, and surrounding all of this is something called an ICB, technical for integrated care board. Yeah. So the ICB sit across the whole of Sheffield. They commission some services for everyone to use. So essentially, when you're seeing people, you might be seeing people that work across all these different levels. And to add to the complication, you get people working in GP surgeries, okay? You also get people working in hospitals, and sort of in between is community care. So you might have seen community diabetic specialist nurses. And I think probably what's going to change over the next 5 to 10 years, possibly, is this is going to get a lot bigger. And we're probably going to get people that historically work in hospitals moving out to the community more and more. This is where the sort of government's pushing things in this direction. Okay. If anyone has any questions partway through, just feel free to ask. So you're probably wondering, why does it matter that to sort of tell you about all these different roles? Well, trust me, as a GP, I find it complicated enough. I've been working in the job for a number of years, so I find it complicated. So I think, you know, it's important that we would explain to patients why you're seeing different people and where it can be beneficial. Hopefully it makes it less frustrating as well, because sometimes I've worked across GPs and PCN levels, and sometimes we get patients that are quite frustrated because they don't understand why they've seen a certain person or why a certain person can't or can't do certain things. Ultimately, I think it's about seeing the right person as quickly as possible. And the right person is not always a GP, it's not always a nurse. And the other point to make is that good diabetic care, it's not just about your test results or your drugs, it's about looking after you as an individual, looking after you as a whole. You know that people that are stressed or struggling in life financially, for example, they may find diabetes. Yeah, sorry.
What's metabolic health?
So metabolic health, so your metabolism, so how your body, it's just how your body looks after its own works, and yeah.
What's the effect?
So your metabolism is sort of everything, how your body runs. So your hormones, the proteins in your body, how your body manages sugar spikes and things.
So it could be all year round.
Your whole health, your whole general health. Okay, so when we think about metabolic health, we're thinking about diabetes, but things like thyroid conditions, things like how your weight's managed, that's all part of metabolic health, general health.
Is there anything else that isn't metabolic health?
Arguably, no, there isn't. So it's but it's it is.
Well, metabolic health would maybe have an effect on our bits of health, but some of it is pretty off to the side of metabolic health.
Yeah, and diabetes, it's one of the probably it's the largest condition within sort of metabolic health diseases. And so it's about looking at you as a whole and how we can help you as a whole. So there's two little caveats though. All GP surgeries operate in different ways, and even though there's lots of people working in different roles, there's a lot of crossover now in different people's roles. So you might find there's a physiotherapist who actually runs a normal clinic and sees minor illness. So there's a lot of crossover now, and that can be a little bit confusing. But I'm going to go through all the roles sort of individually now. So. Yeah. So we're going to first go across the people that provide medical care. So people that might prescribe, diagnose, investigate. Okay. So we've got your usuals. Okay. So the people you're probably used to seeing, the doctor, this might be GPs. You've got trainee doctors. So we were all trainees at some points. So a note about trainee doctors, that all trainee doctors will have someone that's supervising them, and they'll have someone that if they've got questions about can ask on the day. So don't get too concerned if you're seeing a trainee doctor. They will have a mechanism in place in the surgery in order to help you if they don't know the answer. Okay. Nurses, and there's lots and lots and lots of different types of nurses now. So we've got practice nurses. Even within practice nurses, we've got nurses that do sort of standard nursing care, and then we've got nurses that will do things like prescribing and seeing minor illness. And then we've got specialist nurses like diabetic specialist nurses. So nurses in themselves are a whole remit of different types of nurses. And then we've got healthcare assistants. So these are the people that you might see who do your blood pressure checks, your blood tests, and that sort of thing. And then.
So if somebody's called a practice nurse, could they be a prescribing nurse?
They could be, but they might not. Not all nurses are prescribing nurses. So so it's you have to do. Probably Katie's the person who will know more about this, but usually to be a prescribing nurse, you have to do a further course and a qualification in order to be able to prescribe. So pharmacists, so you're probably used to going to senior pharmacists to get your medication, but more and more now there are pharmacists that are embedded in primary care. So they're embedded in the GP surgery. They can do a whole host of different things. A lot of them are there to do things like medication reviews. So different practices work in different ways. So some people have an annual review process. Some of that will, in certain practices, may go to a pharmacist who can look at all the medications you're on, decide whether it's safe to continue prescribing, or whether certain medication doses need tweaking. Some of these pharmacists also look at things like hospital discharge letters. So if you got admitted or you saw one of the hospital diabetic teams, they would then make sure those medication changes are done. They're also supported by pharmacy technicians who aren't pharmacists, but again, they've got some qualifications in looking at medication reviews.
Oh, I've got
Yeah.
a question.
Okay.
So for people with type 1 diabetes,
Yes.
these medication reviews, like everyone understands them, knows why they are, but when you try and do a repeat prescription request
Yeah.
and it's insulin,
Yeah.
and then the message comes back, you need to be reviewed before you can request more insulin.
Yeah.
And even though we know
Yeah.
it's going to get sorted out, it's life. You just think, I'm going to die, because we'll die without our insulin. And this weekend, some person had to go 111 to get an insulin prescription. And I just wish we could get our insulin, and that didn't depend on the review all the time.
Yeah, it's a really tricky one. I think a lot of the times that happens is because there's slight delays across a lot of processes. So if you see a hospital team, they will then have to dictate out a letter that usually goes to the hospital secretary. The hospital secretary has to write it, gets sent through to the GP practice, gets coded by a receptionist, then someone at the practice has to action that task. So a lot of the times people will see someone in a hospital service and there is a bit of a delay. Ways to sort of subvert that as much as you can. I think when you're seeing someone in a hospital team, if it's like an immediate change or that needs to be done, I'd always encourage them to try and email the practice with immediate action, okay, because that'll just happen quicker. A lot of the times practices might be a little bit reluctant to change something unless they can see on the system. And usually, actually, most of the diabetic teams, when they do write something, we can see it on the system. So sometimes, different practices obviously get accessed in different ways, but if you have to do online requests, what's very helpful for us is you can say, I saw the diabetic team on this day.
It isn't always about changing medication. It's like you might have been on the same insulin for the past 6 years, but then there's a delay in getting it when your review's due, and you don't even know that your review's due. This is
So yeah, I think it's worth finding out from a practice how that review process works. So our practice, and it's not going to be the same as every practice, we invite all our patients for an annual review on their birthday month.
Yeah.
So our patients generally know that when it's a birthday month, they're going to get invited for a review. Someone's going to do a load of blood tests, blood pressure checks, and all this, look at the medication, and then renew the prescription. So I think the next time you have a medication review, just check with the practice what the review process is. And yes, it's our job as practices to be as proactive with that, but it's also very helpful if, a month or two before the review process, just to say, bring up the surgery and say, look, I think I'm due a medication review. Can I get that in place? Yeah. Sorry. Yeah.
The process of informing GPs is done by email.
Yeah.
Well, in which way is the communication done that's not as quick?
So, well, to us, most of the diabetic teams, when they write something, it is actually on our systems that we can see if our practice has a similar system to the hospital team. Sometimes, if it's for example, you might see a consultant specialist, this perhaps slightly less so for diabetes, but for other specialties. But generally what happens when you see a consultant, they will dictate out a letter, okay, that goes to a secretary. The secretary will then have to do some coding and write it out, and then it'll get sent through to a practice. Okay, and then at the practice level, there's a few more steps that go on. If they can send so this is for things like a sudden, if you want a medication change to happen quickly, we usually need the authority from a hospital team. So a quick email to us just to say, please can you change this person's medication to XYZ? We'll be able to action that, but it's sometimes hard to action it if we don't have that. But usually email works a little bit quicker. If we can't see the information already.
Last time I went to had a change of insulin. The consultant at the hospital gave me a prescription and said, go and pick this up at the hospital and they have. Well, would it be a good idea to, if they say, well, we want to change your insulin, to ask them to, can you give me a prescription to pick it up now? Could we do that?
From a hospital consultant?
Yeah.
Yeah, you can, yeah.
Yeah.
And sometimes what's useful, if sometimes they give you a copy of that, it's really useful to bring that into the surgery. Okay, so even if we're not going to prescribe it again, then the surgery will have a copy there and then. And the receptionist can then scan it into your record. We can just see what it is straight away.
But perhaps even go out to their reception and say, then you're going to copy.
Yeah, that's and we do sometimes have patients do that, so that can be really handy.
Couple of points. Going back a couple of years now.
Yeah.
But I got a script from the chemist that said that medication review required.
Yeah.
And so I rang the doctor and said, when is it? Didn't involve you.
Yeah.
I said, it is about what I'm taking, you know. I think that, you know, nobody's ever asked me to particularly still suit you and coping with that. Nobody said, but
Yeah.
13 years, nobody said that.
Ooh, they should be. Okay, they should be.
And they, this thing, the wife insulin. Now, I went to take it from the chemist along with Bill.
Yeah.
They haven't got any insulin. They asked me if I would mind driving to one of their other branches.
Yeah.
I said, well, see, it's insulin. I am. I said, but I'm disgusted that you're not able to obtain the insulin.
Mm.
It took me about an hour to go to their, I wouldn't say the nearest branch, but the branch that you've got the insulin in stock. And I felt a bit,
Yeah. Oh, understandably. I think just going to your first point, medication should be reviewed. I mean, really, if you're on a list of long medications, that should be reviewed by someone. Now, different practices have different processes for this. Okay, some practices have a process where they will, like in our practice, we have this annual review process. The patient comes in for their blood tests, blood pressure checks. It gets sent to a pharmacist team, okay, who will then look at the medication. And if, for example, you know, let's say for example, you're just on metformin, you've done your HbA1c blood test and it's fine and it's within range, the pharmacist will usually just renew the medication because it's a simple medication review, okay? Now, if there's something more complicated, the patient's on lots of drugs, the HbA1cs are completely out of whack and things need changing, that should then trigger a GP appointment. So that, you know, that's how it works in our practice, but some practices will, that review process may be more of a sort of safety check. So it's, you know, are your blood tests up to date? Are your kidneys okay? Yeah, they're fine. Okay, move it along. But I'd encourage you, you know, if at any point you feel like I want to reconsider my medication, I want to step down a medication, I want to change medication, I would book a review. And what I do is I'd ask you practice who that's best with, because sometimes that will be with pharmacists or equally a GP can do that.
I have mine with pharmacists.
Okay, yeah.
We have a telephone conversation, I can go and see him. He goes to everyone.
Yeah.
He asks me what side effects I get.
Yeah.
And if there is one, he'll say, I can change that to something else. He also asked me something, and I told him that I was having really bad reflux. So he actually sent that to my GP. My GP made me appointment to go and something else. So they interact quite well.
Yeah.
So I don't necessarily have to see the GP. He will check with him, and then the GP will do what everything is necessary.
So yeah, that's a good, yeah. it's a good example of it working well. And I think, yeah, as I said, slight change in processes in different practices.
Also,
yeah.
the pharmacists that get the medication from, if
Yeah.
it's a new medication, then they will ring you to check if
Yeah.
you're getting on with it. And if
Yeah.
you're not, they will then say, well, we can always put back to the other one.
Yeah.
So they do it, it's a little check.
Yeah. Yeah.
Maybe we need some pharmacists next year to talk about their experience
Yeah.
and their processes.
Yeah. I mean, I think it's not just with sort of diabetes in mind, but I know that nationally there's been a lot of struggles with medication shortages, and you know what you described about having to go to another pharmacist to go and get a medication. That's sadly is becoming a little bit more common. And we're try and keep up to date with it as much as possible. But it's not, sadly, it's not an unusual experience that. I think, again, if you're on a medication on for a long time, most pharmacists should be fairly proactive actually at ordering your medication.
That puts the pharmacist, I
Yeah.
think, you know, it takes 2 months,
Yeah, yeah,
all these, once you're on action,
yeah.
unless you die, you know, it's going to continue.
Yeah. Definitely worth speaking, because if the prescription's done from the general practice, unfortunately we don't have much control about what then happens. And once it gets sent out to the pharmacist, it's in the pharmacist's remit of how quickly they can get that medication. So I think if it's something that you're getting on a sort of 2 monthly basis, I would, say, look, I'm going to be asking for this every month. They should be making sure that that's in stock. So that's definitely something worth.
Fairly common thing, go
Yeah.
on over 2 or 3 days,
Yeah,
you know, still waiting for things.
no, absolutely.
Is there any, sorry if I missed it, but is there any is there like a feedback pipeline? Because recently I ordered, on my repeat prescription,
Yeah.
I ordered Freestyle 2 sensors.
Okay.
I had to go to 3 pharmacists.
Yeah.
And they told me that they are struggling to get them.
Yeah.
So my first pharmacist, the one that got sent to, they had to put it back on the spine
Yeah.
system. And then I went to 2 other ones.
Yeah.
And the first one I called up, they didn't have it. And then they said, if you still need it tomorrow, we should have it. No, in fact, I called 2 and I got it from a 3rd one. The first 2 didn't have it. The last one I went to, they had it.
Yeah.
And then I looked at my repeat prescription and I looked at the history and I found that, because they said it's they can't get it as much because there's 2+. So the one guy told me there's a shortage on this 2 sensors,
Yeah.
Libra 2, because they're phasing it out.
Yeah.
So it seems like there should be something in place there where my prescription now gets reviewed automatically and
Yeah.
updated.
Yeah.
And put on 2+ without me having to.
Yeah.
But then I looked through my repeat prescription and I found a bunch of pens, and I found that I had tried to order them.
Yeah.
Like twice over the past year, and I never got a new pen. And one of them had a funny note on it. I can't remember exactly what it said. And one of them, I know I asked the pharmacist specifically, and they said they can't get it. So these 2 pens are obviously they don't make them anymore, or for whatever reason you just cannot get them.
Yeah.
And so I now have, if my pens break, I don't have a backup. I can't just order a new pen. So
Okay.
there's no I don't know if there is or not, but it seems like there's not a feedback loop going back to the GPs to say, hey, the guy ordered this and we actually don't have it. We don't have any supply.
Yeah.
In order to get it to him. I don't know if there's a thing.
So there isn't an automatic loop there. Sometimes medication shortages could be pharmacy specific, so it might be that particular pharmacy don't have Libra 2.
He told me
So-
they got loads of Libra 2 pluses,
Okay, yeah.
so they can't get
Yeah.
pluses, 2s anymore.
Yeah.
Yeah.
So it's not an automatic thing, and sometimes those shortages could be pharmacy specific,
Mm.
or they could be a more national issue. Usually, if it's a national issue, or there's the pharmacist's aware that there's a supply issue with this, they will send a message back to your GP surgery to say this thing is not in stock. can you prescribe an alternative?
Mm.
And there'll be someone within the practice, either the on-call doctor or a pharmacist or a pharmacy technician, who will do that switch for you.
Okay.
It's not always a good idea to permanently change it, because sometimes those shortages are just a month or two, when we sometimes change those prescriptions just over a month or two and do what's called an acute script. So you just get that one off, and then you go back to your typical medication.
Yeah.
So yeah.
Okay.
But
I need to basically get onto the GP about it.
yeah.
Yeah.
I think if you go into the, if GPs or anyone's prescribed you something, you go to the pharmacy, you go to 2 pharmacists, for example, they don't have it, just ring the surgery back and just say, I can't get this, is there an alternative?
Yeah.
And they should be able to change.
Because it depends. In my mind, I looked at the 2 versus the +2, or the 2 plus, and you get an extra day or whatever. It's different. They've improved it. But in terms of the pens, I'm like, well, as long as I dial 2 units and it delivers 2 units, I like this pen. Why do I need one with this tinsel on it? That's what my perspective. I like this pen. I've had this pen for years. I have, my association is that's my background pen. That's my fast acting pen.
Yeah.
Maybe it's tactile, and so why do I need a new one? Why do I have to get a new one? So that's why it's like, I think it got missed on reviews where the GP was like, "You've got this pen." I'm like, "Yeah, pen, good, good pen, great."
Yeah,
but it's not available anymore. So
no. And I think that's why the review process. I mean, one thing you don't want to have is lots of different pens doing the same job on your repeat prescription. That's probably dangerous if anything. So that should be tidied up.
I've also been in a situation where, they've pruned the prescription list before, but I've been in a situation where I've gone into the consultant, and there's somebody in the back. I'm like, what? And they're like, "Oh, is it okay if they're here?" And they're actually pushing a product. So it's like, I don't want to change, but there has to be a difference between there is an option available and wait, hold up, you have to change because the system's changing and this isn't available.
So a lot of those bigger changes, if someone says all these types of pens have to go out, that's actually done at that ICB level, so at the really wider level.
Right.
So the whole Sheffield ICB might say, this sensor, this pen is getting phased out. We need a replacement. That's done at a level high, much higher than GP surgeries.
Right.
So that happens, and it's not because of an individual drug rep from into a practice. It'll be something citywide. I'm just going to move on, just because I'm just wary of time. That's okay. Hold on. So we're speaking about pharmacists, physiotherapists. You're probably wondering why I'm speaking about physiotherapists. Might not seem all that relevant to diabetes, but obviously we know that movement is one of the biggest things that can help keep your sugars down. So anything impairing your movement is going to affect your diabetes. And what we've got now a lot of times is what we call first contact physiotherapists. So if you contact your surgery with some sort of joint problem, you've had a fall, something's hurting, and you need a review, rather than seeing a GP, you can go straight to seeing a physio. And this is really good because these guys are the experts at all those sort of conditions, and they can help you rehabilitate much quicker. Some of them can also prescribe, so some of them might be able to prescribe medication. So if you need pain relief, you might be able to prescribe, and they can also provide sick notes if they've got the right sort of qualifications to do that. Again, they can also refer back to the GP if they think it's not a musculoskeletal problem, or refer onwards to more specialist physiotherapy if needed.
Do you go in this section and say anything?
Yeah. So it may or may not be offered.
They have you got first contact
Yeah.
video and kind of see them.
Yeah. So this is sort of separate to the Sheffield wide physiotherapy service, but it's not available. Well, I don't think it's available to every single PCN, but some PCNs will have it. And it's an excellent way of, seeing a physiotherapist quickly. One thing to know, they don't provide ongoing physiotherapy. So they're not there to sort of have 8 sessions with. They're really there to just do an assessment, see what the problem is, give you some advice, and give you some exercises to do. Also got paramedics, so might be quite relevant to anyone here, but people needing home visits. Now we do have paramedics that work within practices or PCNs, and they can come out and visit you at home if you require a home visit. Again, they'll have some form of GP or clinician that they can run things past if they're not the answer. And usually they're there for sort of minor illness. So if you've got chest infection, you've had a fall, you want checking over, yeah, they're great to be able to provide that care. And there's a lot more. Okay, so again, some places will have things like dietitians within that PCN level, podiatrists, the people that look after your feet and ankles. I've also written physicians associates. There's a lot of things in the press about physicians associates, and they're probably becoming a little bit less common in general practice at the moment. But essentially they're healthcare physicians who work under the supervision of a doctor. So they can provide assessment and investigations.
Like
with,
when I say physician's associate.
Yeah.
I think it's somebody who's associated with a physician.
yeah,
And I think of a physician, maybe it's being American,
Yeah.
as being a GP, a doctor.
Yeah.
Now, when you call these people a physician
Yeah.
in the non-bolded bit.
Yeah.
What do you mean calling them a physician?
so they're not a doctor. Okay. Well, physicians here is referring to someone that can take a medical history, make an assessment, make a diagnosis, and then investigate or treat a condition under the supervision of a doctor. To be honest, this name of physicians associates is getting debated at the moment. So I think they're thinking of renaming it.
So what's a
yeah.
physician? You just told me
Yeah.
it's there's a thing called a physician, which is
Yeah.
includes doctors.
Yeah.
They're
Yeah.
physicians. There's also
Yeah.
nurses are physicians, are they?
Yeah, so you could say, I mean, a prescribing nurse that will do an assessment, we refer to them here as physicians.
All right.
Yeah, it's slightly confusing terminology, but that's why I wanted to make it clear that they're working under the supervision of a doctor, and prescribing and investigations will go under following advice from the doctor. Any other questions on that?
What do you define as a doctor then?
A doctor is someone that's had a medical degree and went to medical
Right.
school. Oh, why is it not working? Oh, okay. So they're all the people that can treat you medically. Okay, do things like assessments, investigations, manage you with medications. Now I'm going to move on to, there's a lot of people now working in practices that can support you in other ways. So we've got an increase of health and wellbeing coaches. So I don't know if anyone's had any health or wellbeing coaching in the past. Any experience in that? No. So coaches, I think, are fantastic and very sort of underutilized in medicine. So these are people that are qualified to help you make positive changes about your health and your well-being in general. Okay. And what they do, so they're not there to diagnose conditions or anything like that, but they're really focusing on what matters to you as an individual and what you can change yourself. So they work on helping you develop skills, knowledge, confidence, and yeah, they're fantastic. So I mean, again, varies place to place, but if you have access to a health coach and you want to be motivated to, improve your diabetic control naturally, I think these guys are the best people for it. So yeah.
Our GP practice used to produce quite an informative newsletter.
Okay.
They've not produced it for the last 2 years. And I said, what's happened to the newsletter?
Yeah.
They said, oh, we're thinking about producing one. She said, what's the question? I said, well, I'm seeing 4 different people who want samples, who want another meeting to talk about the results of the samples and da. I said, but it's 4 separate appointments. 4 separate samples, and I'm keep back the 4 different feedbacks on those. She said, well, we've got about 30 GPs working for us now, and I was floored by that because I only know of about 5, and I should have asked where are they?
Yeah.
Well, it's probably in the next layer up, isn't they?
Well, yeah, and I guess going back to what I said earlier, practices are now a much larger organisation. So I think sadly one of the things that suffered a little bit from that is continuity of care. You know, people used to get very used to seeing the same GP, but I guess the volumes that we're seeing are now much, much higher. And sometimes that's not as easy as we'd like it to be. And I think if you asked any GP, they'd say, I'd love to see my patients all the time. But sometimes it's just not practical with the volume that we're getting. I mean, one thing I'd sort of encourage is if you want to see the same GP, when you're requesting those appointments, do ask for that. I think the thing to be wary of is sometimes there might be a longer wait if you want to see a specific person. And I guess it depends what.
A lot of them work part-time now.
Yeah.
And a lot of, well, I say a lot, a significant number have taken early retirement.
Yeah.
Of 2 practices I know about. And
I know something from like a government level they're looking at sort of trying to get continuity back in, because it's one of the unfortunate consequences of making practices larger is that gets a little bit lost. So they are looking at that. And yeah, I'm not sure there's an easy answer to that question, but I know it's getting looked at. There's also people called care coordinators. So these are, I'd sort of compare this to like equivalent of a tourist information hotspot for anything that is non-medical that you need support with. So, for example, if you wanted support finding out about local walking groups, local charity services, local volunteering services, a diabetes charity that might be based in your local area, these are the guys that'll know what all the services are in your local area. So there can be, and things like financial support, they can help with that. So they'll know who to talk to. And actually, usually this stuff, if you're going to see a GP about it, we're probably not the best people to ask. The care coordinators that'll know all the local services that are around your area. Okay, because this is something that's always changing. There's loads of charities that pop up, lots of groups that pop up time to time. These guys will know the details of those services, how you access them, when they're doing whatever they're doing. Okay, and sort of going hand in hand with that are people called social prescribers. So these are a bit like your tour guide. So if you need help accessing services, you're struggling to do it yourself, you can get referred to a social prescriber. And what they can do is they can help you along the way. So they can help with referrals, they can help with the sort of attending those services and engaging with services if you need that. And they provide a bit of ongoing care. So I'd encourage, if people need support in those areas, ask about a social prescriber. Also receptionists. I know receptionists probably get a bit of a reputation, but they are really here to help you, and they know a lot about how your practice runs. Be kind to them. I've worked as a receptionist before I was a GP, and it's definitely not an easy job. It's not an easy gig. I think they answer an incredibly large volume of calls, queries throughout the day. But they can be really helpful, and they can tell you who best, a bit like this presentation, who best to see for that problem and how you can be seen quicker. So they'll know a lot about how the practice works. So, I know some people have questions about medication reviews, who does them. A receptionist in a practice usually will know that process. And then we've got secretaries, very similar. So secretaries deal with all the incoming and outgoing posts. So we as GPs do referrals that go through to the secretarial team. They're having to dictate those letters out, send them across to the hospitals. They also help, if we've referred someone and someone's chasing up what's happened to that referral, it's the secretaries that can help with that. And they do a lot of work liaising with the hospital teams as well. Well, that's it, really. Is there any more questions? Or-
Sometimes you find what's happening to your referrals on your NHS app.
Yeah.
Under your actual GP, so they're usually under there if you, and it does say if you've not contacted by a certain time, then ring this number.
Yeah,
So you can
absolutely.
find that, and I'm not sure if the one about your social care and things like that is not on the Sheffield Aches and Pains. There's
Yeah.
a section at the end in one of them where it lists all other things that you can get in touch with.
Yeah. So depending on your area, there might some areas. So where I work, there's something called Woodhouse Community Forum, and they're the centre point for all those other services. So
Yeah.
they've got a website or a Facebook group, so that's a good place to start with that. Yeah, and I think if everyone hasn't, definitely download the NHS app. That's going to be used a lot more going forwards, and it's a really good app. It's actually really easy to use for ordering medications. You know, you can see your results and things on there. So if you haven't done that, I'd really encourage that. Cool. Anything else? No? That's it. Okay. Oh, so yeah.
The health and wellbeing coaches, how ongoing can that support be?
So it depends what this what if there is one in your area for a start. So there's different services. So in our area, there's it's run by a service called Hero of Health. What do you know? Which practice are you?
No, it's fine. I know Hero of Health.
Okay, yeah. So Hero of Health have health coaching plugged into their service. So you know, from our area, we sort of signpost people to Hero of Health and health coaches. I think it depends on how those services are commissioned. So it'll depend. So some health coaches may work with someone for 6 weeks, 8 weeks, something like that.
Like in most practices have like the social prescribing link workers, community workers, navigators within the practice, and most practices do have care coordinators attached.
Yeah.
It's just finding out what the need, what your need is, and who fits that better. Is it the care coordinator or is it the social prescribing workers?
As I said, coaches may or may not be within your area, but yeah, a care coordinator is the right person to ask to find that out.
We've got these leaflets about the NHS app if anyone wants them.
Any online ones, David?
Nope, nothing for online.
I'm going to do them So next one is Katie Whitehead. And Katie's been a practice nurse caring for people with diabetes for 18 years. Well done.
Me and Flex night.
And she's also worked as a practice nurse, educator for South Yorkshire Integrated Care Board, focusing on care of young and adults with type 2 diabetes. And she's also a lead nurse for my primary care network and helped to run chronic disease support groups for our network patients. And she's also a physical activity clinical champion for South Yorkshire, and she's a freelance trainer for Peak Health Coaching, delivering training and in-health coaching, and she supports Diabetes UK nationally through their Council of Healthcare Professionals. So well done, Katie. Thank you very much. So over to you.
Thank you. So, well, I'll try and be quick so that we fit everything in. So if I start going too fast, because I do have a tendency to talk fast, and it's not making sense, then just wave at me or throw something at me, something like that. So I just wanted to talk a little bit about our annual diabetes review, and how the staff in primary care and GP practices can help you through your annual review, because I sometimes feel that some patients that I see are maybe a bit reluctant to come to their annual review and maybe think that they're going to be judged or blamed, or, you know, it's not going to be a good experience, which is really sad, because myself and all the other nurses I know, you know, are just really want to help people and support people, and we only get the chance to do that if they come and have a conversation with them. So yeah, so hopefully this will help. What do I point it out?
One.
No, it's not.
It's not.
Okay. So everybody with diabetes should be on a diabetes register at their GP practice, and this should trigger automatically for you to be contacted once a year at least for your annual review. The review might be with a GP, most likely it's to be with a nurse or practice nurse, but it could be with a nurse practitioner. Some places a pharmacist might do it, sometimes another healthcare professional might do it, but certainly practice nurses do a large part of the diabetes care. You often see a healthcare assistant or similar person first to have your bloods taken, maybe your blood pressure, your weight, possibly even your foot check as well, because that's a good way of gathering all that information. So we've got all your results, so that when you then come and see the nurse, we kind of know a bit more what we're dealing with and what the situation is. Oh, wrong way. So what you should expect to have done at your annual review, or around the time of your annual review, at the very least are these basic checks, which are called the sort of 9 key care processes for people with diabetes. And this is as per NICE, the national body, and Diabetes UK, and all the bodies basically that are interested in diabetes would say that this is the absolute basic of what you should have as your care every year. So that's your HbA1c, which is that blood test that measures your average blood sugar, your blood pressure, cholesterol blood test, a kidney blood test, and also a urine sample to check how your kidneys are working from the urine perspective. Weight monitoring, your foot check that tests your pulses and your sensation in your feet, smoking status check, and your eye screening. Now, the eye screening is slightly different in that that's not usually done at your GP practice. So you'd have to go to either the hospital or a community venue for your diabetic eye screening, which is the photograph of the back of the eye, the retina, which can be damaged through diabetes. So those checks should all be done at least once a year. The eye screening has now gone for some people to 2 yearly, so that's the only exception to that. And on top of that basic care, if you need it, Diabetes UK would suggest that you should also expect more frequent HbA1c testing if you need it, if you're maybe your control's a bit high, or you're doing things to improve your control and you want to see how it's affecting your bloods. Weight management support, good quality care in hospital, obviously, if you need to go into hospital, specialist support if you're planning pregnancy, psychological support, mental health support, peer support like this amazing group that you've got here in Sheffield, access to diabetes technology if you need it, and within the guidelines of what we're allowed to use, and advice on physical activity. This is not an exhaustive list, but it's just an idea of some of the things that you may want some help with. So this is Diabetes UK, the National Diabetes UK sort of guideline, I want to say, but suggestions really of what you might want to think about to have a good quality conversation when you go for your diabetic review. So maybe before the appointment, think about what areas of your diabetes care you want to focus on. You know, if there's anything in particular worrying you about your diabetes, if there's anything affecting your general day-to-day well-being or impacting on your day-to-day activities to do with your diabetes, or maybe if there's anything that you've seen in the news or in something you've read or listened to, new research or treatment that you want to just maybe ask a little bit more about. And maybe, you know, it's a good idea. I always write things down. You know, it might be a good idea to just make a little list of the things you might want to talk about just to keep things on track. Your needs should lead the appointment. Now, the caveat to that is that sitting there as the nurse or whoever's doing your review, we have certain things that we must cover and we must do to ensure that we're giving you the right quality of care. So there will be things that your nurse will want to do and talk about and cover, but that shouldn't exclude you and you expressing your needs. So, you know, try to make your voice heard. And if you feel that things are being you're being railroaded in a direction you don't want to go in, then just try to speak up. Or, you know, if there are things that needs to be discussed and there isn't time, maybe ask for if there's any sort of follow-up call or something you could access, to make sure you've talked about what you want to talk about. And yeah, talking about how your diabetes is affecting your life, not just, there's sometimes maybe a feeling that it's all about numbers and tests and, you know, targets and things like that. But actually the most important thing obviously is how you're feeling and how you're coping with your diabetes. So that's really important that you try to talk about that. And hopefully you'll leave with a clear plan of action and a follow-up if you need it. So I've just put some of the things, sorry, I know it's a really busy slide, but you'll get the slides, won't you? So you can like look at these in a bit more detail. But I just put down off the top of my head some of the things that I commonly refer people to or signpost people to when I do diabetic reviews, just to make sure that people know the sort of things that are available. So obviously there's the Desmond course, which is an education course that anybody with diabetes is entitled to go on. Type 2 diabetes, that is for. I realised I didn't put Daphne on there, which is the education course for type 1, people with type 1. But that has to be done through the diabetes specialist nurses. So that's why I don't refer to that. There's various nutrition education sessions in Sheffield where the diabetes dietitians run something called Carb Smart, and that's to teach you all about the impact of carbohydrates on your blood sugars. There's Sheffield Talking Therapies, which can provide mental health support. So that's for things like stress, anxiety and depression, and you can self-refer to that or we can refer you to that. You can get support around weight loss. There's the type 2 diabetes remission program, which is the, you may have heard of the very low calorie diet for a period of 12 weeks, and then a year's worth of sort of counselling and support to help reintroduce a healthy diet. Quite specific criteria for people who can do that program, but that's there for the right people. I did put the prevention program on the bottom of there. I appreciate if you're going for your diabetic review, you've already got diabetes, so that you're not going to be on the prevention program. But it's interesting to know about for maybe friends, relatives, you know, that there is this 12-month program for people who are at risk of diabetes. And more weight management support in the shape of something called More Life in Sheffield. And there'll be similar programs in other areas of South Yorkshire, like a 12-week group sessions, that is, for people who are wanting to lose weight. There's also a digital weight management program, which is an app version of a weight management program that people can access. There's Healthy Living with Type 2 Diabetes online education, which that's open to anybody. You can just freely access it through the internet. And there's the brilliant Diabetes UK Learning Zone, which you can look at sort of education tailored to your specific needs. So it's absolutely brilliant resource. So I signpost a lot of my patients to these sorts of things. Move well. Ras talked about the importance of movement for controlling diabetes, and it's absolutely vital. And as Shirley said, one of my other posts is physical activity clinical champion. So that's all about helping actually healthcare professionals to understand the benefits of physical activity for treating medical conditions, basically. So in Sheffield, we're lucky enough to have something called Move Well, which is a sort of resource, I'm going to call it, that anybody can access. You can self-refer to this, and again, I refer patients sometimes, and it's basically a resource that tells you about all the opportunities for moving in the local area. Some people just need to have access to that information so they can navigate it themselves online. Some people need somebody to help them and guide them, and might need a bit more support to sort of talk about what their needs are, their particular needs, and then they'll help you and point you in the right direction of what might be useful for you. So real big plug for Move Well, because it's a fantastic resource and we're very lucky to have it in Sheffield. Somebody's already mentioned Hero of Health. Again, we're really lucky in my primary care network because we have Hero of Health, which is an amazing bunch of people who provide walks every day of the week from one of our GP practices. They provide online health coaching. I'm running with them a diabetes education and cooking course in the evenings. So it's just a wonderful set of resources. They're gradually spreading, and you've got them, haven't you, Ras? And they're in another couple of areas in Sheffield. So hopefully they'll just scale up, and eventually everybody will have Hero of Health, and that would be be my dream. And these are just a few resources that these are not NHS endorsed. This is not official. These are things that I signpost a lot of my patients to because I just think they're great and they're really interesting and they're really accessible. There's a couple of podcasts. There's Dr Chatterjee, Feel Better, Live More podcasts, and Rupi Aujla, who's called Doctor's Kitchen. He does brilliant podcasts all about different aspects of health and well-being, and it's all about self-managing, about utilising your aspects of lifestyle to live better and feel better, basically. The Zoe podcast is also really good on similar sort of topics. And then there was a question about metabolic health, wasn't there? This is a resource made by a GP called Campbell Murdoch, if I remember his name right. And it's a brilliant guide to metabolic health. So if you're interested to know more about that, and it includes like a 12-week program to improve your metabolic health, which when we talk about metabolic health, we're talking about things like your blood sugars, your blood cholesterol, your weight, how well you kind of process the food you eat, all this sort of side of things. So that is a brilliant and interesting resource. Just had to put this plug in for Farah and I are working on a project for younger people aged under 40 with type 2 diabetes, because this is the fastest growing group of people with type 2 diabetes under 40s. And these people are at much greater risk of complications of diabetes. And it's a really, really serious condition if they develop it under 40. We're trying to improve general practice staff's awareness of this fact, and also to try and help engage with people of this age with more appropriate resources and material and education. So the ICB, which has been mentioned already, has made this resource that people can access online, and also some support for GPs, a GP toolkit to help engage with this cohort of patients more successfully and more helpfully. So that's just a real shout out for that. So just to sort of summarise, you know, your practice nurse and the whole team that Ras talked about, we're there to support you with your self-management. You know, we're there and we want to help with it. Tell them what you need help with, and ask what resources are available. As Ras said, it's different in different areas and in different practices, but a lot of the things I mentioned are available citywide and should be available to everybody. Try to prepare for your annual review, you know, so that it best serves your needs. You know, don't let it be dictated what direction the conversation goes in if you've got things that you definitely want to talk about and you want some help with. And feedback to your practice if you're not feeling good. You know, we will, practices are very good at responding to feedback. And I was just thinking, Lindsay, about something you were talking about with your insulin. You know, I'd encourage you to feedback to your practice manager, because we take things to MDT, don't we, to multidisciplinary people's complaints or things people note. We discuss in meetings with all the practice, and we try and work out how to improve things and, you know, avoid it happening in the future and that sort of thing. So we rely on feedback from patients, and make sure all your yearly checks are up to date, those key care processes that I mentioned earlier on. Thank you for listening. And thank you for coming to this event.
Any questions, anyone?
I was just wondering whether at the annual review, the nurse could do the medication review at the same time.
In theory, yes, if they're a prescriber, and if the practice system allows for that. Personally, I'm not a prescriber, but I will. And again, this depends on who you see.
Yeah.
You know, I'm interested in diabetes and I've been doing it for a long time. Therefore, I will look through all the diabetes medications when somebody comes to see me, and I'll assess whether they're working, whether they're right. I'll talk to the patient. I'll make recommendations about changes to medication. Not everybody will be as confident with that as me, and then other people will be more confident and be able to do the prescription. So this is the issue, is that it kind of depends who you see. But yeah, in an ideal world, wouldn't that be great if you could just come and see one person? Yeah, but then it also might take a really long time. But yeah, but I hear you.
David, any chats?
No questions online.
You're up.
Thank you very much. So next up we have Dr Seleena Thukral, who's a GP. And Seleena is a local GP with an interest in diabetes. She has clinical experience in both GP and secondary hospital diabetes care. She strongly believes in the importance of holistic approach, thinking about the whole person, their life and priorities, and continuity of care to support patients on their healthy journeys. That's right, what everybody needs because we don't get it.
I was going to say, first of all, before I get started, we've talked about kind of move more a few times, and I'm aware we've all been sitting for quite a while. Does anyone want to just stand up, turn around, have a stretch? I know I certainly need a stretch after a few minutes, so feel
Does
free
anyone
to,
want cold water
yeah, have
without
a,
sitting?
that would be a good time.
What's your last name?
Thukral, Thukral. You can call me Seleena.
What practice are you at?
At the Hollies Medical Centre. I work for Katie.
Yeah.
Yeah. Oh, this one? Yeah. My Elvis Presley. Like that. I've got a whole session going on over here. Sorry, I'm just doing it. No, I'm a bit impromptu. It's actually gone. Yeah. Have another session on that. Yeah. Just wait for them to get some water. Wait a few minutes for those guys, or get started? No, just let them get some water. I hope everyone at home is also having a stretch. Can you see them online? Any stretching? Do names. Come on, Sharon, stand it. I think we're probably close to ready. Is that okay?
Yep.
Okay, so hello everyone. Yeah, so my name's Seleena. I'm a GP in Sheffield, and I work closely with Katie at the Hollies Medical Centre. I just want to spend a bit of time talking about why we do what we do in primary care. I'm not going to spend so much time on the kind of like public health reasons for looking after our patients with diabetes. I think as Katie's referred to, we are all probably aware of the rising rates of diabetes, particularly type 2 diabetes, quite rapidly, globally, and across all age groups, so that's children, adolescents, and adults. But I'd like to focus a bit more on why we do what we do for our patients with diabetes on the level of an individual going to their local GP practice. I guess in summary, it is because we want to improve a sense of well-being and think about quality of life, because that's what matters the most. Yeah, thanks. So I found this article in a journal. It's called Diabetic Medicine, and it's entitled something along the lines of what have we learned about quality of life over 25 years of diabetes care. And this was actually written in 2019, so it's nearly 10 years already. And I think it kind of summarised things perfectly, which is why I just put a snippet of the introduction here. So the quote at the top says, "The shoe that fits one person pinches another. There is no recipe for living that suits all cases." And I think that refers to the fact there's no one size fits all. And I've just highlighted a few bits in this introduction, which I thought were really pertinent. So living with diabetes requires lifelong self-care, demanding a high commitment from the individual if both long-term health and quality of life are to be protected. The demands of diabetes self-management do not sit easily with the unpredictable and high-paced nature of modern life. Indeed, there is often a conflict between what is required for optimal daily diabetes self-management and optimal daily quality of life. In a society increasingly focused on instant gratification we are continually asking people with diabetes to subscribe to delayed gratification, sacrificing today's quality of life for the promise of tomorrow's. And to ensure that interventions are tailored to suit the individual and protect what matters to them, we need to value and assess the impact of diabetes and its treatment on quality of life. I suspect many of you will relate to that, so we'll talk a bit more about that. Oh, sorry. Now, I've always thought about having diabetes, whether you're type 1 or type 2, is a bit like having a full-time job that you didn't really ask to have and you can't really easily resign from. And then, funny enough, I was thinking about that for the presentation. The next day, I saw on the news this comedian who has type 1 diabetes and described it in a very similar way. And I guess what I wanted to say is, I think in primary care, we try to recognise that having diabetes of whichever type does present multifaceted challenges, all different impacts on your life. And I just wanted to spend a bit of time on that. Oh, sorry, I keep going the wrong way.
Are we going to get these slides?
They would be available, yep, yep.
So I've tried my best to kind of group areas of life which, you know, we experience diabetes impacting, but I appreciate all of you are expert patients, and I'm really sorry if I've missed out anything. I'll be very happy for you to come and let me know afterwards what I've missed out on. In terms of physical impacts of diabetes and diabetes care, I think a lot of attention is given to that. So I wasn't going to spend so much time on that today. I know that we've touched upon diabetes checks and the physical checks that are done, but if anyone wants to talk about that a bit more with me, I can talk afterwards. If we move on to the kind of cognitive impact of diabetes, having diabetes and looking after it, I think it's important that we recognise in primary care that the kind of cognitive load of somebody with diabetes is very high. So all the things you have to think about. What am I going to eat? What am I not going to eat? When am I going to eat? When am I not going to eat? Have I got my medication? Have I got my prescription sorted for my medication? Has the medication arrived? Is clearly something we've talked about today. Have I got all the equipment I need for my diabetes monitoring? And that is then layered upon the fact that everyday life obviously throws everything else as well. And so I think it's really important in primary care that we are supporting our patients with diabetes with those things and the rest of life, but taking that on board and remembering the impact of that. And then in terms of the emotional aspect of having diabetes, I think in primary care we get to see a whole range of things. We see some positive emotions. So for example, patients who've had undiagnosed type 2 diabetes, they've had high blood sugar, they're not sure why they felt so awful. It's diagnosed, they start to feel better as their blood sugar comes down, and they're feeling happier is lovely. Patients who are focused on trying to conceive or have a healthy pregnancy can be, really inspire us with their positive attitudes and their determination. But equally, we understand that the cognitive load and the impact of diabetes can be associated with some low mood and anxiety, particularly when there's conversations about fears of complications in the future and those worries. And so it's really important in primary care that we're thinking about those things and addressing that and appreciating that everyone's diabetes journey is different and their needs might be different at different times of their life. And we also experience and support patients with other emotions like anger and denial, particularly at the time of diagnosis sometimes, and that association that sometimes with kind of higher risk-taking behaviours, and there is support available for all age groups for those kind of things. So I've written domestically, and I was trying to think about the practical day-to-day things that diabetes can impact. So driving, travel planning, applying for insurance, employment, particularly if you do things like shift work, and all those things you have to factor into your life, particularly if you have diabetes and you're on medications that can cause a low blood sugar. And I think, in our diabetes checks, it's interesting, isn't it? We saw those 9 key areas, they're very black and white, but perhaps this is something that risks getting underestimated or missed in our diabetic reviews because we don't have a black and white test, like a blood test for how is this affecting your day-to-day life, and just perhaps something we all need to be really, really aware of. And I would encourage you to bring up in your consultations if it's impacting you. And then I've written social. So we know that having diabetes, looking after your diabetes can impact social interactions, whether it's with your family, friends, dating somebody, colleagues, and we have some patients who are diabetic ambassadors, like many of you, kind of proud to share your experience and educate others. And sadly, we have patients who have felt the need to hide their diagnosis from either their loved ones or friends, or hide away to inject insulin. So we really want to be able to support our patients with managing those difficult interactions and emotions, and hopefully making a more positive experience. And then I've written the word identity. So I think it's important to remember that we are all human beings who sometimes have a medical diagnosis, but we are not our medical diagnosis. Your patients who have diabetes and live with diabetes, and some patients are don't mind being called a diabetic, but I've certainly met some patients who don't want to be known as a diabetic. They want to be known as Sandra or John, who happens to have diabetes. And I think it's really important that we are mindful about labelling and that we're not stigmatizing patients in primary care. And as Ras and Katie have talked about, thinking about the individual as a whole, and with their own kind of views. And I think in terms of identity, how we design diabetes management plans should also take into consideration people's personality. So, for example, there are some patients who might like routine and structure, and therefore actually the routine of diabetes care might feel quite intuitive for them, whereas other patients can be very spontaneous and may not gel with those kind of that way of life and find it more challenging. And so rather than saying, well, no, this is the only way, you have to change your life for this medication, perhaps we need to recognize that we can be flexible, that we are so lucky there are more medications and technology and approaches to diabetes now than ever before, and we should be utilizing that to help our patients live their life in the way that's meaningful for them. Keep going backwards, sorry.
Very counterintuitive.
Thank you for that excuse. So in terms of diabetes assessments in primary care, I think it also presents an opportunity for us as healthcare professionals, but hopefully also for you as patients, to think about your diabetes care beyond medication. I get the feeling sometimes that patients expect a diabetes review just purely to be about, okay, this is your test result, we've got to add this medication or do this to the medication. But there is the opportunity for so much more beyond that. So I've written preventative strategies. So those are things to try to enhance health that are not directly related. So whether it's things like flu vaccination, high dose folic acid for women who want to get pregnant, contraception for the women who don't want to have an unplanned pregnancy, statins for people who want to avoid cardiovascular disease. Those are really important. I've mentioned technology. Oops. Sorry, I think it's gone back. Technology, obviously we have the continuous glucose monitors and insulin pumps for some patients, and that's been absolutely revolutionary in helping patients to understand their own diabetes more in real time. I've written connection, so I think I've certainly come across some patients who've developed diabetes that has almost kind of forced them to have to consider medical appointments they never would have done otherwise. And in a way it's allowed, and perhaps they'll say, oh, do you know what, before I had diabetes, I never even went to the GP, didn't even know who my GP was. And through those kind of structured contacts, they've been able to perhaps build a relationship with their GP practice and the people who work there. And that's hopefully, if it's been positive, allowed them to develop a rapport that's allowed them to open up about other aspects of their health that might not be related to diabetes at all, and enhance their well-being indirectly in that way. I've mentioned education, so I think Katie's already touched upon the variety of educational courses, whether it's Daphne for type 1, Desmond for type 2, and the pre-diabetes courses. We also have the NHS exercise referral scheme across Sheffield, which we're really lucky to have to support all patients with any type of diabetes to have a 12-week programme where you can have one-to-one support at one of the local Sheffield sports centres like Graves or Ponsforge and Hillsborough to kind of find a way of getting active in a way that works for you and considers all your different health problems, which I'd really strongly promote. We also signpost community, so you guys are like the best example of the benefits of having a tribe of people who understand where you're coming from, understand some of the challenges and things that you face, and we know that that really enhances a lot of patients' well-being. I've mentioned innovation and research, so I'm not sure if some of you are aware that there are GPs and nurses who are involved in research, so they might work some days of the week in your GP practice and then other days of the week at perhaps a university, doing research to try to improve diabetes care and well-being, and that's really exciting and hopefully will improve diabetes care across primary care. I've mentioned the reversibility of type 2 diabetes. So I think this is a really exciting space. The fact that certainly since I graduated, there's this increasing recognition that actually we can reverse type 2 diabetes with certain kind of actions, and particularly some conditions that can increase the risk of type 2 diabetes. So namely sleep apnea. So there's definitely a rise in the rates of sleep apnea, I think globally, but certainly in the UK. And I've had patients where they've either been diagnosed with pre-diabetes or type 2 diabetes, through talking about things, talking about their life, we've realized they've got sleep apnea, and through treating the sleep apnea, they're able to reverse their diabetes. So I think it's important that we keep an open mind, we remain optimistic, and as I say, think about the patient as a whole, and what their life looks like. And then lastly, I've mentioned maternal health and intergenerational outcomes, and this is a bit of a pet passion of mine. I think, the NICE guidance, for example, recognise that women who are pregnant, young families, are in a vulnerable stage of their life. And actually, we know that the health of a mother and or parents of a young family can significantly shape the health of those children. And the higher the rates of type 2 diabetes in pregnant mothers, the higher the rates of type 2 diabetes in all of those children. So anything we can do to improve the health of a pregnant woman or a family with young children will improve the future and future generations. So now I just want to touch upon why we test what we do, but also what can alter or influence the outcome. Just because sometimes it might feel like we're being quite annoying and asking you to repeat a test, or saying that, giving you a result that you may think doesn't really make any sense compared to what you know about yourself. So hopefully some of these things relate to the things that Katie showed you in the diabetes check. But for example, the HbA1c, which is what we use to check your average blood sugar over a 3-month period, can be influenced by things that affect your red blood cells. So for example, if you've become anemic, if you've had a blood transfusion for any reason, if you've been really, really ill, so for example in hospital, if you've had a problem with your kidneys, whether it be a transient problem or a sudden new longer term problem, or you've had a pancreas problem, like you've developed pancreatitis. And so what I wanted to show you with this slide and the next is that context is everything. When you have an investigation like a blood test or a urine test, it's not just black and white that is this test positive or negative. You always have to understand what's been happening in that person's life to interpret that test, and also to question whether it's accurate. Kidney function, of course, can be impacted by dehydration. So for example, if your diabetes review is due, you're meant to go and see the healthcare assistant for your blood tests, and you've just had gastroenteritis or food poisoning, then factoring that in, or maybe mentioning it when you go for your review is important, because it will alter the interpretation of your tests. Liver function, if you've had a flu, if you've had a cold, that can make your liver function look funny. You've had to have antibiotics for anything in a couple of weeks before your diabetic review, or it's been your birthday and you've had a bit more alcohol than usual. All these things can alter your results slightly, and rather than there being some sort of panic that it's something to do with your diabetes, it could just be simply explained by understanding what's been going on in your life. Blood fats, cholesterol blood tests can be altered by eating a fatty meal just beforehand. And then more for perhaps patients with type 1 diabetes and autoimmune disorder, we do intermittently sometimes check other blood tests that look for other autoimmune disorders. So things like your thyroid function, celiac disease, and a condition called Addison's or adrenal insufficiency. And again, these can be impacted by other things. So for example, if you've been quite poorly or in hospital, your thyroid function can look as if it makes no sense whatsoever. If you've chosen for other health reasons to follow a gluten-free diet, which some people do sometimes, for other problems like irritable bowel syndrome, that can lead to a false negative celiac test. And with the adrenal test, if you have it at the wrong time of day, so anything after 9:30 in the morning, that can make you look as if you've got a problem you don't have. So I guess, again, it's just about sharing what's going on in your life and making sure you're fully informed about what you're having tests for. Is it this time? And just perhaps some other clinical things, blood pressure. If you've missed the bus to your diabetic review, and you've had to, felt really stressed, rushed there, and your blood pressure's up, again, it's context and making sure that we're aware of these things when interpreting your results. If you've had some bad news and you're feeling really anxious, just letting us know so we can always contextualize things. Yes.
Just when you're talking about
yeah,
variable.
yes,
Why is it always that the lowest blood pressure is recorded on your medical notes?
I think often we'll do things like the best of three and often take the lowest number. And I think that probably is just in recognition of the fact that often there are other factors that will contribute to the blood pressure going up, and actually it's your body's ability to regulate your blood pressure that will then generate that lower one. So unless you're unwell, so for example, you've got an infection and we're worried that a low blood pressure is due to something else, in somebody who's otherwise well, it's I guess we're looking at your body's ability to regulate your blood pressure as close to the normal range as possible. Does that make a bit of sense? Otherwise I can try and explain it differently. So I guess, are you worried that by recording the lowest blood pressure that we're missing the higher readings? Is that what crosses your mind?
Always, when I ask them
Yeah.
which one they've recorded, they
Yeah.
said, yes, that one,
Yeah.
that lower. the
Yeah.
lower one.
Yeah, I'm sure there's probably a study that I can't quote to you that's been done, because I know, certainly across my career, whenever we check blood pressure and we find it's high, they'll always say, well, do the best of three, take the lowest one. When we counsel patients to do a blood pressure diary at home, we'll say, okay, if you get a funny one at home, do the best of three, record the lowest one, don't worry about recording all of them. I don't, Raz and Katie, do you know any other reason why?
I guess it's that effect of, usually when people come into a healthcare setting, they get a bit of what we call a white coat effect. So usually your first blood pressure is a bit falsely elevated, and if you do 2 or 3 readings, it just naturally settles. And actually that's probably where your natural blood pressure that's why we ask people to do home blood pressures, because actually it's about having your blood pressure in your natural environment that really means more to us than what can happen in a practice where it's really high.
But your body, generally, the way the body functions is always aiming to restore balance. And so I guess if you take a blood pressure, the first one's high, you take the next one, it's a bit lower, you take the third one, it's a bit lower. It's almost, I don't know, I would see it as a signal, as it's been high, but your body's doing its thing to try to bring it back down to an average. Don't know if that kind of visual helps. So we talked urine protein. So you'll find that often at your diabetic reviews, we ask you for your first wee of the day, ideally, to check how much protein is leaking into your wee. And again, the time of day can impact that. So there is a reason we ask for the first wee of the day. But also, again, if you've been poorly, if you've had a fever, got a cold coming on, that can give a false high reading. Eye screening. So if you've had quite a rapid drop for whatever reason in your HbA1, sorry,
I was just saying about that rapid drop. So the HbA1c in itself is over 3 months, isn't it?
Yeah.
So you're saying that when you go for it affects what's happened 3 months before. You're not saying about a hypo.
No, I'm not
Saying
talking about
3
hypo.
months.
So what we know is that in patients, perhaps, for example, who are put on a treatment regime where they might, or if they have some sort of illness where there's a really big or quite a big drop in their HbA1c, that
Over
can,
the last 6 months.
yeah, probably over more of like a 6-month period, 3 to 6 month period, that can impact what we find at the back of the eye.
But is that good? I mean, are you saying that a good drop in HbA1c could cause a bad drop in retinal screening?
So a really steep drop in HbA1c, unfortunately, there have been concerns that it can accelerate disease at the back of the eye, which is why the aim would always be to kind of gradually bring somebody's trigger down rather than make it plummet really fast.
Why is that? If it's simple to explain.
Yeah, I think it's due to something called oxidative stress, which is that at a biochemical level, when you suddenly change things, sometimes the body creates these little chemicals, they're called free radicals, which I don't expect to mean anything to anybody, but it's how that kind of impacts the cells locally. I don't know more detail, but I can certainly find out and then send a link to you guys if that's better. But in the general approach has been that if there's a really steep drop, so let's say if somebody has a HbA1c of 90 and lots and lots of medication applied in, and suddenly you do your next HbA1c 3 months later and it's gone from 90 to 50, that would be a really steep drop. And
how would you know it's not the medication that's doing that?
It would potentially be the medication doing that, but then that might mean it's too much medication too quickly.
Oh, I see.
So it's the drop in glucose rather than.
It's the drop in average glucose over time. So it's not a hypo, yeah. So I'm not trying to say each time you have a hypo, you're damaging your eyes. That's not what I'm trying to say. I'm trying to say that I guess as a general approach over a period of 3 to 6 months.
But the chances are if you've got a drop in average glucose, you are going to have more hypos. Yeah, but hypos
Yes.
are short term.
Yeah.
Yeah,
but
And
you're
I'm
unlikely
to get a job like that without having changed your.
Yeah.
Change it, you know, if you've got that good at control, to be able
Yeah.
to get a drop from 90 to 50.
Yeah.
Without having any hard pose.
Yeah.
Somebody's got you get your
Yeah.
that book.
Maybe this, I should also check whether this is the context of type 2, because obviously type 2 we have injectables, but also oral medication, and often patients are on a combination. I think in type 1, you know, you're more likely to be on insulin only, and you're going more likely to have technology or more monitoring of your blood sugar. I guess our concern would be there are some patients with, say, type 2 diabetes who might be on something like metformin, empagliflozin. These are medications where you don't have to monitor your blood sugar. You don't even get given a glucometer. And then, for example, if they privately go and get Manjaro, these analog, these injections, and we only find out about it when the HbA1c has gone from 90 to 50 because we've incidentally done a blood test. I guess it's just about having that awareness that, you know, of course, there's so much encouragement to control your blood sugars, but actually in certain contexts, like if you've already got bad eye disease, and if you have the mindset, oh, I need to really get my sugars down, and you go and buy some private thing, you don't perhaps have a conversation with us about it. We can't say to you, oh, look, this is definitely going to help your eye disease.
So are you saying that you know that the effect is there, but you're not really sure about what it is that the people are doing that affects it? Or do you know?
Say that again for me, sorry.
Are you, well, to me, lots of things, if somebody's getting from 90 down to 50 in 3 months, as you just said, it depends what medication, depends on a lot of things.
Yeah.
So are you saying you know there's effect there, but you don't know exactly what's causing it?
I'm
Or
saying,
do you
yeah,
know?
we know there have been some concerns, but not all patients, but some patients who've already got maybe like moderate eye disease, having that kind of sudden big change in their blood sugars over something like 3 to 6 months seems to actually make their eye disease track temporarily worse. And so we just need to be careful of that.
Be interested if you've got any.
Yeah, I'll find you a paper. I've had a paper on it.
Because it seems to me as if you've got, I can't imagine somebody going from 90 down to 50.
Yeah.
Without at times having the equivalent blood glucose having gone well down below.
If you're type 1,
see it though,
yeah, we see it.
with these Manjaro and, you know, what they call GLP-1s, these injections. That
So they're not getting high dose.
yeah,
They're going down
they're
without
not.
high dose.
No.
Also, women, oh, sorry, Katie, but people who are preparing for pregnancy can make radical changes in their diet and really bring down
more frequently because they have to get their sugars down really rapidly.
You're saying when the HbA1c is dropped a lot, you might get more oxidative stress.
Yes,
And
in
can
the
you-
eye.
Can you think why?
I can't explain that to you off the top of my head, and I don't, because there's a risk I'll tell you something wrong. So I'd rather find the link I had and then I'll send it. Is that okay?
This therefore was surely when people first diagnosed, say type 1, and they go on insulin, then it must drop a lot, or mine did drop drastically. Obviously when you go on insulin, it can be very high and you go low.
Yeah.
So I got a massive response of breakdown of the skin on my shoes. It went purple and broke down. And I could only put it down to the massive drop in blood sugar. So
But I guess with I guess all I would say is perhaps with type 1, when you were diagnosed with type 1, generally it's not, my impression is it's not something that simmers in the background and then necessarily suddenly happens. It's relative. I mean, how old were you, for example, when you developed? 50? Okay, so a bit later on. So I do think there's a risk that this paper maybe relates more to type 2 diabetes, and I'm wary. I don't want to be misleading here. So with type 1, it generally tends to be something that happens over a short time period, probably to your pancreas, right? Whereas with type 2, people can be undiagnosed for years and years and years. So that damage to the eyes is happening over years and years before a diagnosis even takes place. Then there's a diagnosis, then there's treatment. So that may be intensive treatment at the beginning of being diagnosed with type 1. You may not have that kind of degree of background disease in the eye in the first place that a type 2, who's perhaps had a delayed diagnosis, has already accumulated without knowing. Is that okay?
Did you say it's like temporary, or it actually exacerbates
Again,
long
I will
term.
double check because I'm wary that I'm not an eye specialist, and I came across it, and just something again to be that we have to be mindful when we're doing our diabetes check. Always looking at the trend of things, and then what's the implication of this trend. That's what I guess I was wanting to point out. I'm sorry, I feel like I may have kind of caused a lot of anxiety, so I will do my best to find some robust information. That wasn't my intention. Sorry.
I think it's very interesting.
Yeah, I was just interested because I know Dr. Brown, as eye specialist, he also said, try and make sure you don't get too many variation in hypos. And I'm wondering whether that's what he was saying behind that, as as well as it could be saying that maybe there's other research that says the more often you go low, the more it can affect the back of your eyes.
Yeah, I don't know about hypos per se. I know with hypos, particularly in older patients, the kind of risk to the heart becomes higher. The risk of a hypo affecting your heart becomes higher as you get a bit older. But I don't know about for your eyes.
Because I'm just thinking you can get lots of hypos and still not have an improvement in HbA1c.
Yeah, if it then swings the other way.
On the other hand, I can't imagine a good drop in H1c without sometimes going hypo. And quite
well, if you're type 1, but not if you, as Katie said, we've definitely seen it in our type 2 patients where they've not had a single hypo. Not a single hypo, but that we've observed kind of big changes like that.
Yeah.
And I've just remembered Professor Heller is coming in July. He's our July presenter.
Yeah.
So he's totally a man, isn't he?
Yeah.
For this?
Perfect person to answer.
If we can just remember.
And then repeat medication list. So I think you've already touched upon the fact that it's really important to do a review of your medication, go through every single one, make sure everything still is appropriate for you, that you can access it. And this really comes into play, for example, sometimes when we get patients who move areas, who change practice, maybe that they may sometimes move multiple times and we don't even have all the notes, and we need to provide their medication. So being able to kind of talk through it systematically one by one, like you described your pharmacist doing, if you're having any side effects, have any problems, is really important. And it's also really important to share with your GP practice if you're using things like private medication, over-the-counter medication, herbal medication, because that sometimes also can influence what's happening with your health. And again, I guess with private, the biggest thing we're seeing at the minute is the weight loss injections that are also used for diabetes care, but there's a massive explosion of private use of that, and that obviously then skews some of what we see. And then contraception is obviously something for kind of reproductive age women that we'll talk about throughout their kind of journey. What I want to summarize is that we aim to care for you as an individual in primary care and an individual who has diabetes, and we try to do this in order to optimize your personal well-being, but obviously do our duty to encourage good population level health, and that's why we do what we do. Thank you.
The HbA1c, can you lower it by giving blood? I think I've heard something like that.
No, I mean artificially, no, actually that doesn't make sense. No, because the HbA1c is basically looking at how much sugar is sticking to a red blood cell. So if you give blood, you're just giving away some of your red blood cells, but you're not gaining new red blood cells with no sugar.
Encourages you to make new blood cells to.
Yes, you will. You're right. But then if there's sugar around, then.
But I think those newer red blood cells won't have had as much time to get glycated.
Yeah. So if you're anemic, so if, for example, you've donated blood and maybe your own level is a bit lower, and if we do a blood test before your own bone marrow has had enough time to make new ones, we should really be able to see that your hemoglobin is lower than before. And certainly if it's lower than normal, we know that that can influence give you almost like a false HbA1c.
So you don't think the fact that some of the red blood cells might be younger than if you hadn't given blood might be associated with less glycation of them?
Good question.
I
don't know about the maturity. I don't know about whether the maturity of the hemoglobin or the red blood cell affects its stickiness, maybe.
Are you thinking, this is what I'd be thinking, okay, so I've got my HbA1c coming up, I'll go and give some blood a week before.
I've heard, artificially make you look like better in that respect.
Yeah, but it'd be a bit unhelpful for
Yeah.
my
Yeah.
overall
Yeah.
health, wouldn't
Yeah.
it?
Sounds like basically what you're doing is you're washing your hands before you do your blood test. Kind of thing. Cause you're reducing the contaminant period kind of thing. Something like that.
I'm not sure it's in your best interest.
Yeah.
but It's your choice.
You might as well just go, because I've got mine coming up and I'm thinking of all excuses not to go, and I think just go. Good,
Yeah.
you're not good waiting, it'll just be the same, so just go. Away.
I'm really sorry, but I'm just mindful, I've got 5 minutes to run to my car before I get a fine. So has anyone got any other questions? Otherwise.
Goodbye.
Will you come again?
And I will find out some more eye information.
Thank you.
Thank you very much.
Okay, yeah, we done. Okay, thank you everybody online. I think we're closing the meeting. Goodbye.
So if anybody just wants to take part, if you want to ask him any question, yeah.